The following podcast is part of a certified educational activity titled Finding the Path to Improved Outcomes in Uncontrolled Persistent Asthma, Applying the Latest Clinical Evidence for Treatment Success. Access the entire activity and complete the post-test at peerview.com/RXX860. Downloadable slides and practice aids are also available.
Welcome to Finding the Path to Improved Outcomes in Uncontrolled Persistent Asthma. Today, we're going to be applying the latest clinical evidence for treatment success. You're probably wondering who I am. I'm Dr. Cedric Jamie Rutland. I reside within Southern California, and I run Rutland Medical Group / West Coast Lung in Newport Beach, California. Welcome to this unique case-based educational activity on diagnosing and managing uncontrolled persistent asthma. This activity will give you the opportunity to explore strategies to confirm an accurate diagnosis and assess disease severity, as well as guide you through the labyrinth of treatment options to optimize care. So, let's get started and see how management decisions can change based on variable patient, disease, and treatment-related factors. So we first have to talk about uncontrolled persistent asthma. So what is it? So first of all, as you all know, by seeing these patients on a daily basis, you know that uncontrolled persistent asthma has major impact on quality of life. People have excessive symptoms, frequent or life-threatening exacerbations, they have other comorbidities, and they have high requirements for pharmacologic treatment in addition to wanting to be seen all the time. Despite maximum standard therapy with inhaled medications, 5-10% of patients with asthma are considered to have uncontrolled persistent asthma, and 69% of these adult patients have either eosinophilic asthma or what we call T2 high asthma, which we're going to get into. Many patients, as you guys all know, are dependent on oral corticosteroids, which have been associated with long-term adverse effects like thinning of the bones and hyperglycemia. About 50% of the patients with severe asthma have more than 3 exacerbations a year as disease severity worsens, compared with 5% of patients that have mild asthma, and even about 13% of patients with moderate asthma. So, what are the important predictors of future exacerbations? Well, exacerbations within the last year, degree of asthma control, asthma severity, and what's called T2 inflammation. So, what's the definition of uncontrolled persistent asthma? So let's get into that. So the first part of this definition includes asthma that's requiring high-dose inhaled corticosteroids, long-acting beta agonists, and other types of modifiers such as leukotriene modifiers, theophylline in the last year, or systemic corticosteroids for more than 50% of the previous year. It's 2020. So if my patient comes in right now and I say, hey, Kathy, what's going on? And she says to me she's been on prednisone, and she's been on prednisone the previous year for more than 6 months, that's uncontrolled persistent asthma. It's also, uncontrolled asthma is also defined as at least one of the following. You have poor symptom control, frequent exacerbations requiring at least 2 doses of systemic corticosteroids, serious exacerbations that lead to hospitalization or an ICU stay, and severe airflow limitation. That is, the amount of air that you can blow out in 1 second, that's less than 80% of what's predicted for that patient. All right? So when you are looking at uncontrolled asthma, those previous symptoms are how we define uncontrolled asthma. And controlled asthma is asthma that might worsen when you taper down that dose of either inhaled corticosteroids or systemic corticosteroids or additional cellular communication inhibitors or biologic therapies. So what is T2 high asthma? We're going to get into the immunology of T2 high asthma, but what you have to know is it's most often associated with an elevated IgE, eosinophilic inflammation, and the patient's response to corticosteroids. And here's something I'm very passionate about, because as we move forward in society, as we move forward, period, we have to understand that this one-size-fits-all for evidence-based treatments may not necessarily be a great thing as it pertains to asthma. We also have stratified medicine, where you have evidence-based treatment groups. So you have different groups of people that are defined in a certain way, and you're going to treat those groups the same way. But now we're moving more towards personalized medicine. You want to take a look at each individual's serum and understand their immunology and what's going on within their bloodstream that leads to those asthma exacerbations, or that leads to the severity of asthma that can become so difficult to treat if you're not paying attention. So let's move to one of the patients that we see typically. We got Kathy. So Kathy comes in, she's 23 years old, she just finished college, she's looking for a job. Right now, she's working as a teacher and a coach for a high school field hockey team. So she's physically active, right? So she likes to work out several times a week in addition to her practice time with her students. She's had asthma for years, since she was a teenager. She's had 2 exacerbations in the last year that required oral prednisone. So her current therapy consists of an inhaled corticosteroid / long-acting beta agonist, and then she uses her albuterol as necessary. When you're examining her, she's about 60 kilograms or 130 pounds. Her height is 165 centimeters and her BMI is 22. So she's in shape. But she complains about worsening symptoms and the need to use her rescue inhaler more frequently, especially when she's interacting with her kids that she is coaching. When she's out there running on that field, she gets really short of breath, and she notices that almost every practice she's using that inhaler. So right now, you've chosen a scenario with the complicating variable of moderate atopic dermatitis and a decision point of conducting phenotyping or endotyping Kathy to understand the type of asthma that is present within her protoplasm. So let's understand what a phenotype and an endotype is. So a phenotype is an observable property of an organism that are produced by the interactions of the genotype and the environment, right? And it's based on clinical characteristics, triggers, general inflammatory processes, and they may not always suggest an underlying mechanism, so we have to be more specific here. Looking at this endotype, we're going to go over specific biological pathways that are identified that can explain the observable properties of a phenotype. So when you look at the definition of a true phenotype or endotype, it's going to require a natural history, it's going to require consistent clinical and physiological characteristics, and it's going to require an underlying pathobiology with identifiable biomarkers and genetics when necessary. So let's talk about T2 high asthma, right? So when we're talking about T2 high asthma, these patients might have a strong family history of atopic disease, which may overlap with other atopic conditions, which include atopic dermatitis and allergic rhinitis. And I would always convince and persuade my residents and my fellows to look at a patient's skin when they come in for a lung problem, because you want to know, does this patient have symptoms that are consistent with a T2 type of asthma, a T2 high type of asthma? It's important. They may have early onset allergic asthma, right, that presents with mild disease or severe disease. And what's also important to note is all of this can be exacerbated by obesity. Because of that chronic inflammation of obesity, this can happen. So as we move into the immunology of asthma and atopic dermatitis, it's almost one and the same. Here's what happens. Now, we all breathe in antigens and allergens on a daily basis in the environment. So once the airway epithelial cells decide to respond to an antigen, here comes a process. This is what happens. The airway epithelial cell is going to communicate with other types of white blood cells, and it's essentially going to start the party that's happening. And then as this party is happening, it's going to start calling and recruiting other types of cells to the area. So once that airway epithelial cell is exposed, interleukin 33, interleukin 25, and TSLP get produced. These interleukins are also called alarmins, or damage-associated molecular patterns. Those alarmins are going to communicate with a dendritic cell, another type of antigen-presenting white blood cell that will then communicate with a naive T cell. Once that naive T cell is under the influence of the dendritic cell, that's when it becomes a Th2 cell, and this is where that T2 activity comes from. Now, that Th2 cell is going to produce certain cytokines that lead to the cellular recruitment and the pathophysiology of asthma. The first cytokine it produces is interleukin 4. Interleukin 4 is a cytokine that's responsible for isotype switching. What does that mean? Isotype switching means that instead of B cells, which produce antibodies, producing IgG, they're going to produce IgE. We all know that IgE is an antibody that will bind to basophils, eosinophils, mast cells, and cause the release of the granules within that cytoplasm. Those granules also consist of cytokines and chemokines. Now, the next cytokine that Th2 is going to produce is interleukin 5. Interleukin 5 leads to the recruitment of eosinophils to the airway. Eosinophils will get recruited to the airway, and we all know that the higher percentage of eosinophils, the more likely you're going to exacerbate. Interleukin 13 is also a cytokine that is produced by the Th2 cell. Interleukin 13's activity is important. It leads to the production of goblet cells. Goblet cells do what? They secrete mucus in the airway. So if that patient of yours has a wet cough, right, and they're coughing things up with their asthma, you might want to be thinking about interleukin 13's activity. It also causes hypertrophy and hyperproliferation of the smooth muscle that surrounds the bronchiole. So you can imagine a situation where when interleukin 13 is active or overactive, so to speak, you're going to get that wheezing because that bronchiole is going to constrict. Now, when we look at the other side of this picture, we call it the non-allergic side. It doesn't matter what it's called, it's the same process, because once pollutants or smoke is brought to the table and brought into that airway, you're going to get the production of interleukin 33, 25, and TSLP, those same alarmins that were present previously, all right? But in this scenario, here's what's going to happen. There is another type of immune cell that's important here. It's called the innate lymphoid cell type 2. It's formerly called the lymphoid progenitor cell. But the innate lymphoid cell type 2 probably produces interleukin 5, interleukin 9, and interleukin 13. And we talked about what those interleukins and those cytokines do, right? Interleukin 5, eosinophil recruitment. Interleukin 13, goblet cell proliferation, mucus production. Also, bronchial hypersensitivity, hyperactivity. So you get that smooth muscle constriction. So here what you can understand or begin to understand is that asthma is an extremely talented and intelligent immunological process. And if you understand that, you can take that to the next level and apply it to the person in front of you. So this is where we get into biomarkers. So let's talk about a biomarker, pheno, right? Which is something that you're going to breathe out at times. When you breathe out that nitric oxide, okay, you have to understand that pheno has a very strong association with interleukin 13 activity. That's the cytokine it's most strongly associated with. And it's also responsible for telling us if somebody is steroid responsive. Let's look at the blood and sputum eosinophils. Again, on almost every patient that I see, they all get a CBC with diff because I want to know what their eosinophil count is looking like in their bloodstream, because the higher it is, the more likely they're going to exacerbate when they have asthma. You can look at IgE. IgE is a marker of excessive Th2 activity as well. Let's look at another biomarker. So urinary leukotriene, right? Urinary leukotriene may be a marker of leukotriene activity, which is also responsible for inflammation and cellular recruitment in the lung. Periostin also is another biomarker that may be responsible for recruitment in the lung, and I know it's responsible and involved in the eosinophilic type of recruitment and pathway. There's other biomarkers, perhaps CC16, allergen skin testing. Again, what you're trying to do, what your goal is to understand what's going on inside of your patient, taking that information, applying it moving forward, and making your patient significantly better. So you're going to order a complete blood count with differential on Kathy, exactly what I would do. You're going to get a total IgE, exactly what I would do. You're going to conduct spirometry along with a test for pheno. Perfect. The results are going to tell you what's going on. Her eosinophils are at 310. That's elevated. Her pheno is 25. That's also elevated. In fact, T2 high asthma shows that a pheno must be above about 20 or so to be T2 high. You can now confirm that Kathy has T2 high asthma, which also explains why she has atopic dermatitis, right? We talked about this earlier. Atopic dermatitis, right, and asthma are associated with one another. And we're going to get into another pathology that's also associated with these conditions. Okay, you've chosen a scenario with the complicating variable of chronic rhinosinusitis with nasal polyps and a decision point of conducting phenotype endotype testing to determine what type of asthma Kathy actually has. So let's take a look at CRS with NP. It often occurs with asthma, and you will also have allergic and chronic rhinitis in addition to exacerbations of this disease. Asthma and CRS with NP are also associated with GERD and sleep apnea. When you look at patients with CRS with NP, okay, asthma has been reported in anywhere from 26 to 48% of these patients. So 50% of these patients can have asthma that have CRS with NP. And I pay attention to that. As a pulmonologist, right, we are not trained to look in the nose very much, but I look in the nose on virtually every patient every time I see them. It's characterized, CRS with NP that is, by type 2 inflammation. It is the same process that takes place in the nasal epithelium, also takes place in the lung. So you have this infiltrate of cells as a result of the presence of antigens in your lung. So your endotype may be moderate type 2 or severe type 2, and your phenotype, you're going to have nasal polyps, you're going to have CRS with nasal polyps, and the biomarkers are extraordinarily similar. You're going to get that pheno. You're going to get that eosinophil count in the bloodstream. You might even want to get an eosinophil count in the sputum. You're going to get that IgE. The leukotriene and the periostin, I don't draw those very much because once the first three are done, you pretty much have your plan and where you're going to go with this therapy and with this patient. So now you're going to order that CBC with diff, an IgE, and a spirometry. And you're going to notice that Kathy's eosinophils are at 310 and her pheno's at 25. All of this indicates that this patient has type 2 high asthma, which essentially tells you that she has antigens in the air that are leading to significant inflammation, not only in her lung and in her bronchioles, but also in her nasal pathway, which is extraordinarily annoying because then she can't smell, she can't taste sometimes, and she's always congested and sniffling. You've chosen a scenario with the complicating variable of usual adherence to medication and patient concern about the need to come into the office to receive biologic or cellular communication therapy if she's eligible, and a decision point of conducting phenotype/endotype testing to determine Kathy's asthma type. In addition to phenotyping and endotyping, it is also important to assess the patient's adherence to medication, obviously, and their disease severity before we can determine their eligibility for biologic therapy. Not all uncontrolled asthma is severe asthma. So the patient may be a person who has moderate asthma, but just doesn't take their medicine, right? So you have to look at their inhaler technique because their inhaler technique may simply be inadequate. So when you're looking and you're trying to address the causes of their asthma control, you have to understand that non-adherence and incorrect inhaler technique are extremely important. So it has to be a priority. So again, when a patient's coming into your office and they're using or not using their inhaler, you have to demonstrate to them how to use their inhaler appropriately. You might also want to talk to them and say, hey, is there something that's preventing you from being able to use your inhaler? Like, is there something that's going on? You know, is it too difficult? Is you get too busy? How can we best help you? If your patient's inhaler technique is awful, they're going to end up in the ED. They're going to have frequent visits with the ED. They're going to have frequent visits with you. So you want to correct those errors. And quite frankly, those errors are easy to correct. So how are you going to determine how controlled someone's asthma is? You guys all do this naturally, right? So people who are controlled are using their inhaler like one time a week, if that, right? The albuterol. If you're not well controlled, You're going to have symptoms all the time, symptoms throughout the day. You're going to have nighttime awakenings. You're going to have some limitation or extreme limitation if you're very poorly controlled with your activity. And you're going to use your rescue inhaler all the time, and your bronchioles are going to be constricted. So your FEV1 may be less than 60% predicted. Either that or your peak flow is less than 60% predicted. So again, these are the things that are going to tell you that the patient's not well controlled or very, very, very poorly controlled. So uncontrolled asthma is determined through exacerbations requiring oral corticosteroids and perhaps the patient having more than 2 exacerbations that previous year. So you really got to pay attention to that. So you want to pay attention to that medication adherence, and you want to pay attention to the degree of asthma control. Is it not well controlled, or is it very poorly controlled? Okay, you've now chosen a scenario with the complicating variable of moderate atopic dermatitis and a decision point of determining eligibility for biologic or cellular communication therapy. And if so, how are we going to decide which one to use? So when you're looking at T2 inflammation, and we talked about this immunology earlier, once that dendritic cell becomes activated by those alarmins and that naive T cell now becomes a Th2 cell, you're going to be producing several different cytokines. So it's important for you, just like it's important to my fellows and my residents, to understand the cytokines that are involved, because the molecules that we're going to select are going to inhibit certain cytokines, right? So you've got interleukin 4, 5, 9, 13, and you want to know which one is probably more prevalent than the other. So you're going to get that CBC with diff, that IgE, that pheno, and you're going to take that information, and there's no book that's going to tell you which therapy to choose right away, right? You're going to have to take that information, you're going to have to use a little bit of art, and you're going to be able to come up with an appropriate therapy for your patient, because you know that when they take this therapy, their exacerbation rate's going to go down, okay? And they're going to feel better, which is the goal of medicine in the first place. So let's think about the different cellular communication inhibitors we have, or biologic therapies that we have. You've got an anti-IgE molecule called omalizumab. You've got 2 anti-IL-5 molecules. And what I mean by IL-5 molecules here, I'm talking about the cytokine Li5. They inhibit the cytokine rosalizumab and mepolizumab. You also have an IL-5 receptor antagonist called benralizumab. And then you have the interleukin 4 receptor antagonist dupilumab, which, because of the dimerization of interleukin 4 receptor and interleukin 13's receptor, also inhibits interleukin 13's activity. And then you have the newest molecule called tezepelumab, which inhibits one of those alarmins, the TSLP, right? Those are the cytokines that are produced as soon as the airway epithelial cell is exposed to something it doesn't like. So tezepelumab is more of an upstream molecule that inhibits that TSLP. Now, when you're looking at omalizumab for uncontrolled asthma, the dosing is weight-based. So it's 3 mg per kg every 4 weeks or so, sometimes every 2 weeks. It's approved for patients that are 6 and older with moderate to severe persistent uncontrolled asthma. And it's more effective in patients that have that type 2 signal. So there is some data to support its use in eosinophilia, as well as its use in elevated IgE. The response is shown to remain stable for 60 months. And this biologic has been out since I think about 2003, 2004. So it's been out the longest. So we have the most data on this one. It increases your lung function and your quality of life. It reduces your hospitalizations, your exacerbations. It also tends to reduce colds in children, probably through the mechanism of the dendritic cell. We're not going to get into that. It also reduces your oral corticosteroids and your inhaled corticosteroid use, as well as reducing that IgA-mediated inflammation. Now we're going to move into the IL-5 therapies, or the anti-IL-5 therapies. Mepolizumab, it's 100 milligrams every 4 weeks. I've used this one a lot. It's approved for patients age 6 and older with severe asthma and an eosinophilic phenotype. So you want to look at patients that have the eosinophil level of 150 or greater. It's effective if you're atopic or not, and in the long term. And in studies to date, the adverse events are very similar to the placebo. So you're not getting significant adverse events. You're getting an increase in your lung function, in your asthma control, in your quality of life, activity, and work productivity. You're getting a reduction in your exacerbations, your oral corticosteroid dose, and your symptoms. Riclizumab was an IV formulation, is an IV formulation. It's 3 mg per kg every 4 weeks over 20 to 50 minutes. It's approved for patients that are 18 with severe asthma and an eosinophilic phenotype. So trials pre-specified an eosinophil count of greater than 400. It's effective regardless of atopic state and in the long term. The adverse events are very similar to placebo. It does have a black box warning of anaphylaxis. There's no data regarding oral corticosteroid sparing, but it does increase your lung function, increases your asthma control, your quality of life, reduces your exacerbations, hospitalizations, oral corticosteroid dosages, and your symptoms. You may not use it as much these days because it's IV and you have all these other subcutaneous therapies, but it's still a very effective drug. Benralizumab is one of the drugs that I really like because it's an anti-IL-5 therapy. The recommended dose is 30 every 4 weeks for the first 3 doses and then every 8 weeks afterwards. It's approved for patients that are 12 and older with severe asthma and an eosinophilic phenotype, but the clinical trials included all comers. It's just that patients that had an eosinophil count of 300 did much better. So again, the higher the eosinophil count, the better those patients did, right? The adverse events are similar to placebo. Dupilumab is another targeted treatment option for severe asthma. The recommended dose is 400 milligrams subcutaneous loading, followed by 200 every 2 weeks, or 600 milligrams, followed by 300 milligrams every 2 weeks. It's approved for patients that are 12 and older with moderate to severe asthma and an eosinophilic phenotype, or with oral corticosteroid dependency. That is, someone who's on some dose of prednisone to prevent the exacerbation from happening. Clinical trials studied all comers, but patients with an eosinophil count of 300 or better did much better. They performed much better overall. Now, when you're looking at the adverse events, injection site reactions were the most common. So when you look at the higher dose of dupilumab, the 300 dose, 300 milligrams every 2 weeks, they had a much higher percentage of injection site reactions at about 18%, as opposed to the lower dose of 200 milligrams every 2 weeks that had an injection site reaction rate of about 10%. I've seen this in clinic. I see this all the time. I don't much less care about an injection site reaction so long as the patient doesn't display any other worsening type of symptoms. You know that with dupilumab, you're going to increase your lung function and your asthma control and your quality of life, which is important. While you're doing so, you're also going to reduce your exacerbations, your oral corticosteroid dose, and your symptoms. So when you look at tezepelumab, which is the anti-TSLP monoclonal antibody, it reduces your annual exacerbation rate. And you can see that here. And you can see the reduction of annual exacerbation rate with the eosinophil count. So the eosinophil count here matters as well. So when you look at the emerging therapies that are targeting asthma and atopic derm, dupilumab does that. Benralizumab is only approved for asthma as of right now, but there's a phase 2 study going on for atopic dermatitis. And then tezepelumab, there's phase 3 data on asthma, right, which we're all going to learn about very soon. And then there's phase 2s going on right now for atopic dermatitis. So when you're looking at dupilumab in the presence of comorbid diseases, again, you have these 3 different indications. You have atopic dermatitis, you have chronic rhinosinusitis with nasal polyposis, and then you have allergic rhinitis as well. So when you're looking at this medicine, understand that you're going to get an improvement in your CT score for sinus congestion. You're going to get an improvement of your nasal congestion score, so patients are going to smell easier. You're going to get an improvement in your atopic dermatitis symptoms, and you're also going to obviously get improvement of your allergic rhinitis. So when you're thinking about dupilumab, understand that you're going to have multiple effects on patients here. So looking at a treatment algorithm, there's no head-to-head studies. So the way that I look at this algorithm, and they try to define this algorithm here. You got allergic, eosinophilic asthma, what you would use. Allergic asthma, what you would use. Eosinophilic asthma, what you would use. Oral corticosteroid-dependent asthma, what you would use. Here's what I suggest, and here's the algorithm. You want to wean the patient off of steroids. If they're on prednisone, you want to wean them off of steroids because you want a naive bloodstream. That's what you want. You want a bloodstream that's not exposed to anything. And then you want to get that CBC with diff and that IgE and that pheno. And you want to understand, does this patient have eosinophilic asthma with an elevated IgE? I might want to use an anti-IL-5 like benralizumab or dupilumab, which is an anti-IL-4/anti-IL-13. You also want to look at an IgE level. If the IgE is elevated and there's no eosinophilia, you're probably going to want to use omalizumab, right? If they have elevated eosinophilia and an elevated IgE, you can use benralizumab, you can use omalizumab, you can use mepolizumab. It kind of depends on your comfort and the patient's comfort. You also might want to look at injection frequency. Does the patient want a shot every 2 weeks? Does the patient want a shot every month? Does the patient want a shot every 2 months? What do they want? And again, what you have to take into account is that sometimes, the patient may get the shot every 2 months, but the medication may have to start having this tapering type of effect where the patient starts to display symptoms maybe a week or two before the shot's due. And so sometimes, having a more frequent shot, if you have that kind of patient, may be more beneficial. So you want to take all these things into account because this is fun. This is where you get to interact, where you get to make that decision along with your patient. So Kathy's T2 high asthma is likely to benefit from any of these approved agents. So she also has atopic derm. So in this case, I'd probably use dupilumab because it's approved for asthma and atopic dermatitis with some of the other biologic agents currently in development for atopic dermatitis, but not quite there yet. So you want to use dupilumab for Kathy. Okay, you've chosen a scenario with the complicating variable of chronic rhinosinusitis with nasal polyposis and a decision point of determining eligibility for biologic therapy. Now, we've talked about this immunology before. So you have this dendritic cell that's going to communicate with the T cell, leading to the production of multiple cytokines, 4, 5, 9, and 13. Now, we all know what those cytokines do now, right? Interleukin 13, goblet cells, right? Smooth muscle hyperproliferation, okay, wheezing. Interleukin 4, isotype switching, right? You're going to produce more IgE. Interleukin 5, eosinophil recruitment. Interleukin 9, mast cell development, okay? So let's pay attention to these things and then pick an appropriate therapy. Now, anti-IgE is omalizumab. Anti-IL-5, rosalizumab, mepolizumab. Anti-IL-5 receptor, benralizumab, along with the antibody-dependent cellular cytotoxicity here. Anti-IL-4 and 13 are dupilumab, and then the anti-TSLP, the tezepelumab. Now, thinking about persistent asthma and CRS with NP, dupilumab's already approved for both. Omalizumab is pending the FDA approval for CRS with NP, but it's approved for asthma. There's some data to support CRS with NP. Benra, there's a phase 3 going on right now with CRS with NP. There's some data that shows that if you have nasal polyposis, you're going to be more responsive to Benra if you have asthma as well. It's approved for that. Mepolizumab, again, you've got phase 3s going on right now for CRS with NP, and you've got some data for CRS with NP, but it's approved for asthma. So again, when you're thinking about the medicine that's the best for nasal polyposis, atopic derm, and asthma, it's going to be dupilumab here. It has this indication of chronic rhinosinusitis with nasal polyposis. And again, when you're looking at the treatment algorithm, the most important thing is to understand the immunology. Understand which cytokines are hyperactive. Is interleukin 4 out there? Is interleukin 13 out there? What's going on in this patient? Is the pheno elevated? All right, pheno's elevated, interleukin 13 activity. They're really associated, so you know that's up there, okay? Now, you know the patient makes a wet cough and produces a lot of mucus. That's also interleukin 13. So you're going to take all these little tidbits of information and you're going to apply them to a treatment algorithm. Now, everybody's going to try to come up with a certain algorithm. Do this first, do this second, do this third. Again, you want to use your own mind, understand the immunology, and apply it for yourself and your patient moving forward. That's what you want to do because there's no head-to-head studies. So we know that Kathy has T2 high asthma, which is likely to benefit from any of the approved agents. Since she has CRS with NP, you're going to tell her that dupilumab is approved for both asthma and CRS with NP, and explain that it is likely that other biologics will soon be approved for asthma and CRS with NP, but you're going to start with dupilumab in this scenario. You've chosen a scenario with the complicated variable of usual adherence to medication and patient concern about the need to come into the office to receive biologic therapy if she's eligible, and a decision point of determining eligibility for biologic therapy, and if so, which one. So we have to think about the goals of asthma management. You want to reduce impairment and future risk. So you want to improve that symptom control, you want to manage the comorbidities, you want to improve that lung function while also reducing exacerbations, reducing the use of rescue medications, and you don't want to have those treatment-related adverse events or the visits to the emergency department. So when you're assessing medication adherence, you need to listen carefully to the patient. And in fact, I have the patient bring in their inhaler. Let me see. When was the last time you filled this? I have my MA call the pharmacy. You want to suggest, alternatives, Inquire about day-to-day management. Put your inhaler next to your toothbrush. You're going to brush your teeth in the morning and in the evening. Put it there, all right? You want to write down advice to patients. You want to educate, tell them, show them why it's important to use their inhaler, right? But the patient needs to understand why they're doing it, right? Why are they using their inhaler? Other than just to prevent them from the ER. When you explain things to patients and you show them pictures of their cells, they really take an interest to this because it's happening in them. And then they understand it. And I'll tell you what, you're going to get more compliance out of that. You may have to refine your therapeutic plan, but you're definitely going to get more compliance out of that. But when you look at the GINA guidelines, you're going to use that albuterol first, and then you're going to add the inhaled corticosteroid. You might increase that inhaled corticosteroid and then add the long-acting beta agonist, and then add other controller medicines like a leukotriene receptor antagonist at step 3. Then you might add tiotropium at step 4, and then you're going to get into the cellular communication inhibitors, biologics, in step 5, right? So you must go this way, and insurance companies require you to go this way. So you might want to put in your note, step 1, step 2, step 3, step 4, step 5, right? And you also have to document maybe how many times the patient's been on prednisone in the last year, maybe how many times the patient's been to the hospital, because you're going to need that supporting document when you submit for these medicines. So when you look at the ERS task force update on severe asthma, again, they're very, very similar, right? So they're going to suggest using pheno. They suggest using CBC with diff. They suggest when to apply certain therapies, right? When you're going to use that macrolide sometimes, when you're going to use the anti-IL-5 therapies. So it's just important to know that all of this is like a stepwise approach, okay? And then when you get to making that decision, understanding your patient's immunology is of the utmost importance. Do they have elevated IgE? Do they have an elevated eosinophil count? Do they have an elevated pheno, right? Which drug inhibits interleukin 4? Which drug inhibits interleukin 5? Which drug inhibits interleukin 13? So have an understanding of what's going on in your patient. Does your patient have a wet cough and nasal polyps, okay? Wet cough, mucus production, interleukin 13. Ooh, dupilumab. Nasal polyps, ooh, dupilumab. Easy decision, dupilumab. So you have to take into account all that. Oral corticosteroid dependency. Now, this one's tricky because I think the most important thing is looking at your patient's bloodstream when it's naive. You don't want them on oral corticosteroids if you can help it. If they do have oral corticosteroid dependency and you want to reduce that dose, you probably are going to use dupilumab or benralizumab because those two drugs are associated with a reduction in oral corticosteroids, right? So is mepolizumab as well. So it doesn't matter what you select. Here, you just have to understand that the immunology is of the utmost importance, and it's something that you should spend your time on. Because as we move forward in time, that's where medicine's going. It's becoming more personal, and that's what's important. So you've expressed this concern to Kathy over having to make time for visit injections. You inform her of the various dosing schedules for the biologics, and she can determine what will be best for her schedule, right? Or at-home administration. You can give Benra at home. You can give Dupy at home. You can give Mepo at home. So you want to understand, for Kathy, does she want the shot every month, every 2 weeks, every 2 months? What does she want? And that's what you're going to go over because that's what's extremely important is the patient.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/RXX860. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.